Well, sorry about the cutoff on the Pharmacology 101. I'm still getting used to this video stuff. This is Pharmacology 101 continued. Well, we were talking about in vivo versus in vitro activity. And your next question might be, well, if a bacteria is sensitive to a particular antibiotic, and you're telling me that it may not be active in vivo, how am I to know whether or not I can use this antibiotic for a particular infection? Unfortunately, this is something that has to be researched. And I'm not saying certainly that you need to know, and you really don't need to know necessarily the drug concentrations in various tissues which are listed and are public knowledge, and what the levels are in various tissues, and whether or not that's sufficient to cure an infection in that particular tissue. What you need then to do is find out if there is an indication for the particular drug in a certain disease. So you would have to, again, look this up and up to date and look for the FDA approved indications for this particular drug against this particular bacteria or for this particular illness. Other than that, you can look up the illness in particular, pneumonia, and find out which drugs have a history of being successful in treating such. So it becomes incumbent upon you to do some research on the drug or the disease to find out if there is historical precedence to use a particular agent for a particular infection. Hopefully that is clear. The next topic, pharmacology topic I want to address is cidal versus static antibiotics. A cidal antibiotic actually kills in vivo, and in vitro, kills the organism in contact, as opposed to a static antibiotic, which just renders the growth phase inactive and doesn't actually kill the bacteria. And the reason people get better, even though the antibiotic does not kill the bacteria, because the bacteria is limited in its growth, the person's own immunology or the own immunity can therefore clean up the rest of the involved organism. So however, there are some, and you should know, infections that require cidal antibiotics. There aren't very many. One of them is endocarditis, which it's clearly shown that requires cidal activity of the antibiotic versus the bacteria in order to cure this particular illness. And it probably has something to do with the nature of the vegetation itself, which really is just platelet, thrombin, fibrin, and bacteria without any immune sort of cells inside the vegetation. So, and since the vegetation really doesn't have much of a blood supply, it has to actually rely on the diffusion of the cidal antibiotic into the vegetation in order to kill the organism within the vegetation. The other very important infection that requires cidal activity is meningitis, is bacterial meningitis. And it's been clearly shown that you have to achieve 4 times the MBC of the antibiotic versus the organism in the CSF in order to cure meningitis. It's unclear why this is so. When I was researching this many years ago, it was determined that one of the reasons may be that there is decreased complement activity within the CSF and rendering the need for cidal antibiotics. The next disease, which is less worked out, is neutropenic sepsis. So there is some sort of immunosuppression or immunoincompetence, obviously, if somebody is neutropenic, let's say from bone marrow suppression from chemotherapy, we tend to opt for cidal antibiotics, which doesn't rely on the host's immunity to kill the bacteria. Some of the medicines that, and this is listed on page 14 in your handbook, that are bactericidal include beta-lactams, vancomycin, quinolone, flagyl, daptomycin. Bacteriostatic antibiotics include tetracyclines, clindamycin, Bactrim, and Bactrim. We can talk a little bit about MIC and MBC. I don't know if you need to know this for your boards, but MIC is it means the minimal inhibitory concentration of a particular antibiotic that will inhibit the further growth of the bacteria in a test tube. MBC is the minimal concentration of a particular antibiotics in micrograms per cc that will kill an organism in a test tube. And static antibiotics have a much higher MBC kill rate compared to the MIC, and thus rendering the antibiotic static. And the organism referred to in that situation of a static antibiotic, the organism is referred to as a tolerant organism. This MIC-MBC issue is diagrammed on page 14, so it might be more easy to understand if you look at that. The other important property of antibiotics, well, I kind of mentioned in the beginning, is bioavailability. But bioavailability simply means if you take an antibiotic and inject it intramuscularly or intravenously or per rectum as a suppository or oral, where in the body will it go? Will it be available? And your main question is, will it be available in the area that I want to treat? So we already talked about daptomycin intravenously. Even though it gets into the lung, it's not bioavailable because it's broken down by surfactant before it can be effective. So there are some oral antibiotics. This becomes more important when we're dealing with oral antibiotics because most intravenous antibiotics that we give are widely bioavailable. However, some are not. Gentamicin won't get into the lung very well, so can't be used alone for pneumonias. Also can't be used alone for meningitis because in some situations meningitis needs to be treated with aminoglycosides intrathecally. But when it comes to oral antibiotics, the beta-lactams are notorious for not achieving the same sorts of levels that we get when we give them intravenously. For instance, it's becoming more and more clear that beta-lactam antibiotics for oral beta-lactams for pyelonephritis may not be as efficacious as the more bioavailable agents for pyelonephritis, such as Bactrim or quinolones, which reach good high concentration in the kidney and the prostate gland for that matter, and are preferred over beta-lactams for pyelonephritis and prostatitis. Other really good bioavailable oral antibiotics include Bactrim, Zyvox, doxycycline, fluconazole, metronidazole. Most of these antibiotics provide the same level of protection and distribution in the body orally, when taken orally, as when given intravenously. So that can be very, very helpful as well. So we talked about bioavailability, we talked about cidal and static, we talked about dosing, excretion, and so forth, and that's pretty much. What we haven't talked about is mechanism of action. I probably should mention a little bit about synergy. about how we can use multiple antibiotics to actually kill a bacteria that otherwise would not be killed. And the most notable is Enterococcus, which again, as you know from microbiology, is the small bowel coccus. And when it comes to being bactericidal or bacteriostatic, even though the organism may say it's sensitive on the antibiotogram to ampicillin, ampicillin will generally not kill the Enterococcus alone, and what is required is synergy with an aminoglycoside. And if you know the mechanism of actions of ampicillin and beta-lactams in general, they bind to the cell wall of bacteria. And whereas aminoglycosides need to enter into the cytoplasm to affect the ribosome and protein synthesis for further growth of the Enterococcus. So and typically at the doses we give, aminoglycosides cannot penetrate the enterococcal cell wall. However, if ampicillin is first given, think of it as poking holes in the wall that now allow a door for aminoglycosides in the dosage we give to enter the Enterococcus. And between the two, the ampicillin and the gentamicin, the organisms die and enterococcal endocarditis is cured. This is a pure example of how we use multiple antibiotics synergistically. So I guess that's about it for Pharmacology 101 continued, and I'll see you on the floors. Thank you for listening.